like to give you some rearrangements of our total program schedule. As you know, in every program, at the end, we used to do a quiz. But from today, we are not going to do the quiz. Rather, we will go for a poll. So before the presentation, there will be a poll. This is not a very tough poll. I would request all to participate in this poll. And we can see how many participants there are really participating in the poll. So before the presentation, there will be a poll. Then there will be the presentation from today's speaker. And after the presentation, there will be again the poll. We need to see whether there is any change in our decision making by the presentation. So I would like, so without any delay, I would like to request our chairperson, Professor M.A. Heiser, to kindly give permission to start the program. Professor M.A. Heiser.
Thank you, Mr. Rahman. Good afternoon, everybody. We have participants till now 19 participants. Hopefully, they will be increasing. As Suman has said, this time we have, instead of this quiz program, we have just switched over to pre-test and post-test system. Pre-test system, which will give you some questions. You just answer it. And then after it is finished, we can give the same questions again to see if there is a change in the response or not. And how many persons that can take part in this. So it will be another type of judging of our own activities. Lecture that we give how much is the participants are assimilating. This is what we are trying to do. So without any delay, someone started. Ask the today's president, Professor Dr. Jahangir.
Thank you, sir.
Jahangir present his paper.
So should we start, sir?
Oh, sure, I told you, sir. Immediately, without delay.
Sir, we cannot hear you properly, sir.
Eh?
Okay. Okay, so we cannot hear you properly, sir.
Why not? You are not listening me?
Shuman sir, you have a network problem, sir. We can hear sir very clearly.
It's okay. It's okay.
Okay, so probably then we have a problem. Okay.
Right.
So Shomir, can you please show the poll to the audience?
Already showed, sir.
Yes, I would like to request all the participants to give their suggestions, give their answers in this poll.
Morning, all. Hi, John.
Hi, Kamal.
Hi, John. Good afternoon.
Hi.
সুমন ভাই পোলে কি একটা কোশ্চেন?
No, there will be another question. We are waiting for the first question only. So still there are some participants who didn't participate in the poll. May I request you, those who still don't participate, please give your answer in this poll.
That there will be award among the poll participants. Suman,
Yes.
did you say that once anybody participates, there is a chance of getting an award from the random selection?
Yeah, I sorry to mention this. So as we have planned, so those who will participate in this poll will randomly select one for the award that we used to give as the to the quiz winner. So today's from these poll participants will select one randomly to give this award. So Shamir, please proceed to the next question.
Should I show the results, sir?
Shamir, can you present the poll?
Result is already on
Yes,
the
no.
result is on the
Most of the attendees are with the side. Okay, next proceed with the next question.
Don't show the result. Next question.
Next, this is the second question.
Why I cannot answer? Samir, I tried, but I cannot answer.
Sure.
Bhai,
Anyone can answer, sir. There is no limitation in this, sir.
But last time I could answer, but this time I cannot answer.
Oh, might be the network issues, I guess, sir. But I can see there is a number of participants they are answering, sir.
Okay, okay. Good question, Shuman. Different type of answers are coming.
hello everybody. We are just randomly answering. I don't know, uh, what's going to happen? Like, this is a random quiz or what? Like,
No. We will, Masum, what we will do. So this is, we want to see the pre-test, post-test, and then from the participants, we will randomly select the best quiz winner. If it is you, then the award will go to Lesotho. Don't worry. So thanks for joining, Masum. So
okay,
this
thank
is
you very much.
he is our medical college junior, Mahan Singh Medical College junior, and I'm so happy that he joined with us.
Thank you very much, Kamal bhai, for inviting.
Thank you for joining.
Yeah, you're welcome, Dr. Mustafa.
Hi, Masum bhai. Assalamu alaikum.
Alaikum
Dr.
salam.
Sajjad, M31.
M31.
Yes.
Great. খুব ভালো ভাইয়া। কেমন আছো? ভালো না?
হ্যাঁ, ভালো আছি ভাইয়া। অনেকদিন পরে দেখলাম আপনাকে।
হ্যাঁ, আমি খুব ভালো লাগতেছে।
Okay, we will proceed to the third question. Shamir, please proceed with the third question. So there is no right and wrong. So I would like to request every participants to participate in the poll. So let's see what ultimately comes at the end.
It says on my end that panelists and hosts cannot vote. So I don't think it lets me.
So the panelists can see the results. That's why they can't vote, sir.
Minutes time for a question is very long time. It should be 1 minute.
Yeah, I think next time,
Yes,
sir.
sir.
The first time we are giving a bit time, but slowly we will reduce the time. And posters
Yes,
will.
there will be one. Okay, Shamit, just close the poll and save the results. We will discuss it later. So now I would like to request our today's presenter, Dr. Jahangir Alam. Let me introduce him first. He is a medical oncologist. He completed his MD from National Institute of Cancer Research and Hospital. And after completion his MD, he got a long training in medical oncology in Rajiv Gandhi Cancer Institute. So I'd like to request our today's presenter, Dr. Jahangir Alam. Over to you, Dr. Jahangir Alam. Dr. Jahangir.
Slideshow, Tada. Jahangir, go to slideshow. Right. Yeah, this one. Okay.
Dr. Jahangir is muted, I think.
Dr.
Dr. Jahangir, can you please unmute yourself?
Okay, M32 তুমি নাকি M31 তোমাদের
M32.
জাহাঙ্গীর
Jahangir,
M32 জাহাঙ্গীর M32
Yes. Jahangir, you can just proceed.
Thank you, Dr. Mustafa, for nice introduction. Honorable Chairperson, respected faculties, welcome to you all in my session. Today's my presentation is treatment of extensive stage small cell lung cancer. Before going to the main topics, main presentation, let's have a look on small cell lung cancer. 15% of lung cancer is small cell lung cancer. 2/3 present at stage 4 with a very poor prognosis. Less than 5% survive at 2 years. That's why it is declared as recalcitrant cancer by US Congress in 2012. In my today's presentation, I would like to cover medical oncological aspects of extensive stage small cell lung cancer management. What should be the standard chemotherapy in first line, whether cisplatin is superior to carboplatin or not, what should be the optimum dose, or what are the options after the first line failure, or is there any scope for third line therapy? And there will be few slides for immunotherapy and targeted therapy. You know, 70% of small cell lung cancer present in extensive stage. The intention of treatment is palliative chemotherapy and immunotherapy. And of course, there's some role of radiotherapy even in the extensive stage. If chemotherapy produce any response, we can offer thoracic irradiation or prophylactic cranial irradiation. All of us know the hallmark of small cell lung cancer is rapid response and rapid resistance. You can expect a very good response after 1 to 2 cycles of chemotherapy, but the response won't last longer. And that is the real challenge. You can see that even in the year of 2020, median overall survival around 11 months, and less than 10% patients survive 2 years. Now, what should be the first line chemotherapy? In the year 1977, this RCT was published, and it proved chemotherapy produced better overall survival than best supportive care. Though these were not the mainstay of treatment even after 50 years. Come to see the history. In the 80s, combination of cyclophosphamide was the treatment. Later in the 90s, cisplatin, etoposide come with the equal outcome but less toxicities. This is the meta-analysis published in the year of 2000 in lung cancer, and proved etoposide and platinum is better than any other combination. And there is another meta-analysis published by Pujol in same year, established the role of cisplatin with 4.4% survival benefit at 1 year. Till date, cisplatin and etoposide combination is considered as a standard of care. Besides this etoposide and platinum combination, few other combinations was tried, but the irinotecan and platinum combination came with good results. You can see the meta-analysis, irinotecan and platinum combination is better. This is a Chinese publication. Though this meta-analysis proved the superiority of IP combination, but some Japanese and some Western group, it failed to prove its superiority. So still etoposide and platinum considered as the gold standard of treatment. Now come to the question whether we can replace carboplatin instead of cisplatin. As we know, cisplatin is toxic drug. Here we can see 4 trials across the world tried to get the answer. In the Cauchy's analysis, the overall survival is equal to carboplatin. Hazard ratio is 1.08. There is no significant difference in overall survival. In the subset analysis, cisplatin only shows superiority in the PFS for those who are less than 70 years. The toxicities, hematological toxicities is more in carboplatin, renal toxicity is more in cisplatin. So we can use cisplatin or carboplatin with etoposide, which will produce equal overall survival. Those who are with poor prognosis, this combination gemcitabine and carboplatin can be used. This is the paper which is published in year of 2009. The UK paper showed that GemCar produced equal overall survival. There is no significant difference in overall survival. Due to toxicities, it was also tried that monotherapy, oral etoposide, is not a very good option. And there was more than 3 times progression compared to the combination group. What should be the dose? It was also tried with different dose scheme, but ultimately it showed that full dose produced better result. You can see the overall response rate 39.3, where the full dose response is 68. It also reflects in the overall survival. whenever we want to treat the patient, we should consider the full dose of drug. Few other stages were tried but failed. Maintenance therapy, different schedule, dose escalation, all failed to produce a good outcome. Some recommendations. The patient eligible or for immunotherapy, the preferred first-line chemotherapy, stage 4, small cell lung cancer. And cisplatin can be substituted by carboplatin, and cisplatin recommended the patients age and toxicity. For some patients, taking into account the age of toxicity profile, cisplatin is recommended. Cisplatin with irinotecan or oral topotecan are alternative treatment options. In poor prognosis patients, gemcitabine plus carboplatin is an alternative treatment options. What should be the treatment in case of second line? As you know, most of the patient relapse within a short duration of time. In second line of treatment, overall response rate is 7 to 24%, and median overall survival is 3 to 9 months. There are two types of relapse. One is sensitive, another is refractory. After platinum therapy, if relapse occur within 3 months, it is refractory. If it is more than 3 months, it is sensitive. Here we can see the overall survival is better for the sensitive group than refractory group. In GFPC 1301 study, the sensitive relapse patient was randomized in 2 arm, less one arm. It was his challenge, carbamide compared to oral topotecan, the standard of care. You can see the carboplatin and etoposide combination produce better PFS. Non-hematologic toxicities more in topotecan, and hematologic toxicity more in carboplatin and etoposide. Whether more drugs combination going to produce better outcome? In this platinum, etoposide and irinotecan phase 3 study, combinations of cisplatin, etoposide, irinotecan is compared with oral topotecan. This combination, cisplatin, etoposide and irinotecan, is better than the oral topotecan. But cisplatin, etoposide and irinotecan produce too much toxicities, so this is not advised in consider. Prognosis of third line chemotherapy is not convincing so far. So further fourth line and fifth line, you can see the third line chemotherapy. PFS is 2.3 months, overall survival is 4.4 months. So best supportive care can be good options for this group of patients. In second line chemotherapy recommendations, patients with platinum refractory small cell lung cancer have a poor prognosis. Either oral topotecan are recommended for the patients with platinum resistant or sensitive relapse. The patients with platinum sensitive small cell lung cancer re-challenged with first line platinum plus etoposide can be considered. This is the era of immunotherapy. Like most of the site, the immunotherapy comes with promising result in extensive stage small cell lung cancer also. In IM Power 133, carboplatin, etoposide plus atezolizumab produce good result. In Caspian trial, durvalumab is produced better result. and Keynote 604 produced promising result. IM Power 133 overall progression-free survival is 5.2 with atezolizumab and with placebo 4.3. In Caspian, negative in PFS overall survival, but negative in PFS and but positive in overall survival with durvalumab. In a Keynote 60 study, here in a nutshell, IM Power 133, atezolizumab overall survival 12.3 and placebo 10.3. In Caspian, EP plus durvalumab 13.0 and EP 10.3. In Keynote 604, EP plus durvalumab 10.8, placebo 9.7. So immunotherapy is always better with combination. Here, single agent nivolumab did not improve overall survival. Look, durvalumab median overall survival 4.8 months and atezolizumab median overall survival 9.5 months versus 8.7 months. But combination nivolumab with ipilimumab is better. Nivolumab and combination is better than nivolumab alone. In short summary, in chemotherapy, in platinum-based combination, carboplatin, etoposide, atezolizumab, durvalumab in first-line chemotherapy, and topotecan and CAB is alternative in second-line treatment. Besides the immunotherapy, some targeted therapy are going on trial, but we have to wait for their convincing result. Thank you for patience hearing.
Thank you, Dr. Jahangir Alam, for your very informative presentation. I'd say that you have tried to cover all the aspects of extensive stage small cell lung cancer management. Now the floor is open for question and answer session. But before the question and answer session, I would like to hear our overseas faculties, John Conivier, to get his opinion regarding this presentation. Over to Dr. John Conivier.
Yeah, thank you for that. That was a really nice overview of where we stand currently in the systemic therapy landscape of extensive stage small cell lung cancer. What's evident from what you presented is that the disease is notoriously resistant to drug therapies that we have available and is described as the elephant graveyard, of new molecules. I think, as you've touched on at the end, last year really saw the first significant step forward in the management of extensive stage small cell with the advent of the immunotherapy era, which showed the first meaningful improvement in overall survival, in fact, for over 20 years, with the results of the Empower 133 study. And now the new standard of care, as you've shown, is to consider patients who are obviously fit and appropriate for chemoimmunotherapy. So thank you for sharing the data this morning or this afternoon, depending on where you are.
So thank you. So I would like to request every participants to put their question in the chat box, because I am not getting a number of questions from there. Only a few questions over there. One question is from Dr. Mufassar Hassan. What is the role of CAF in small cell lung cancer management? Dr. Jahangir. Cyclophosphamide, doxorubicin, and vincristine combination in management of extensive stage small cell lung cancer.
Thank you, Dr. Masum Bhai. Assalamu alaikum. Yes, I know you well because he is my patron of poet recitation. It is cyclophosphamide combination is the first chemotherapy in early 80s. I mentioned it, and it is the better, it gave the better result than best supportive care in that time.
So if you allow me to add with Dr. Jahangir Alam, CAF was considered as the standard of care in 80s. But later in the 90s, there was a paper which was published. I forgot to mention the journal. They found that CAF and EP is equal outcome. The EP produce equal outcome to CAF, but the toxicity profile is quite low with EP. And after that, when this meta-analysis come in 2000, and it proved that the EP combination is better than any other combination. Since then, EP is considered. But before that, CAF was considered as the better combination for small cell lung cancer in extensive stage management. Thank you. There is another question from Dr. Mubassar Hassan. Please mention the role of radiation and palliation. I am not sure because Dr. Jahangir is a medical oncologist. He is not the proper guy for research. So there are a few other radiation oncologists in the platform. I would like to request Dr. F.M. Kamaluddin to say a few words regarding the role of radiation in extensive stage small cell lung cancer.
Well, I was asking that question, but I didn't realize that I'm going to answer the question. So, I mean, this is a very important question that Masoom raised. The problem is we believe that in extensive stage lung cancer, small cell lung cancer, chemotherapy is the player. But if we use EP 4 cycle, and then we see there are some residual in the thoracic region, and it has been shown that adding radiation to this, thoracic area by thoracic radiation, either standard 60 grain 30 fraction, even 30 grain 10 fraction offers survival benefit. So this is a recommendation that if there is after chemotherapy in extensive stage lung cancer, we should think of thoracic radiation. And the group who is having a residual in thoracic region is the highest beneficial. Not only that, if there is a very good response, even in metastatic setup, then also there's recommended that we should think of the thoracic radiation. And even if there is a good response extensive stage, PCI is also recommended. And regarding the palliation, as you mentioned, if it is a metastatic, you know that we use palliation for pain control, sometimes for symptomatic control. We can definitely use radiation when it is required. So it is a chemosensitive tumor, but we should not forget about radiation in extensive stage of small cell lung cancer. John, would you like to add something?
Yeah, so patients, once they've had induction chemotherapy, if they've got residual thoracic disease, my standard of care is to normally deliver 30 grain 10 fractions to the disease that's left. It probably touches on what we talked about last week as well, is do you treat the pre-chemo volume or the post-chemo volume? So again, I treat the residual post-chemotherapy volume. What's interesting is in the clinical trials that have been conducted, so Caspian, Empower 133, and the Keynote study, thoracic radiotherapy wasn't included in those studies. And so if they've had induction chemoimmunotherapy, giving thoracic radiotherapy strictly wasn't in the protocol. So whether you do it or not, I think comes down to personal choice. Personally, I still do. I still think that if you look at the trial data and if you look at the progression-free survival curves, as soon as those patients stop chemoimmunotherapy, a large proportion of them, there really is a sharp drop in the PSF curves. And I think that you can delay that effect by giving thoracic radiotherapy in appropriate patients. A more topical role of radiation is in PCI. So once patients have completed systemic chemotherapy, there is trial data to suggest that giving PCI 20 grain 5 fractions reduces the incidence of brain metastases. There's a more recent study published from Japan, though, that showed futility of PCI if you screened patients initially with MR imaging. So rather than just treat all comers with whole brain radiotherapy, if you select your patients using MR, so not giving PCI to those without brain metastases, and instead adopt a careful watch policy where you where you use serial MR imaging every 3 to 4 months to look for the development of brain metastases and then intervene, it seems as though you can reduce the unwanted toxicity of whole brain radiotherapy without impacting on survival. So that's, but again, it's all about resources. If you don't have access to MRI scanners, then it's safer, I would say, to use PCI, because what you don't want to do is kind of try to adopt it without having access to those imaging modalities for your patients. So that's my take on it.
What John is telling, that he is treating the post-chemo volume. That is very important. And they are using 30 gray, not the conventional 60. Even in the guideline, you have the option to use both, but he is using 30 gray, and the data is telling that even 30 gray, the palliative dose is giving survival benefit. So this is the two message, that in extensive stage, we can use even 30 gray, but it will give you a survival benefit.
So what Dr. Kamal Bhai is going to give the information that even in the extensive stage small cell lung cancer, there is a very good role of radiation therapy. If the patient respond to the initial chemotherapy, so there is a URTC trial that showed that giving the radiation therapy 30 grade 10 fraction, at 2 years, it is going to give around 13% survival benefit, wherein those who are not getting radiotherapy, there is 3% survival. So there are additional 10% survival benefit at 2 years. That is the URTC trial published in the year of 2017 or 18. So definitely there should be a role of radiation therapy in thoracic RT. But if the patient completely responded, there is no lung lesion after complete chemotherapy. So those patients did not get benefit from the radiation therapy. So if chemotherapy produce partial response, there is residual volume in the lung, we should not forget to give radiation therapy 13-10 fraction. So there's another question, what is the role of PCI? It is from Dr. Kamal Bhai. So it is already discussed. So let me argue with Dr. John. So regarding the Japanese trial, though they have showed that there is no overall survival benefit with the PCI, but in the URTC trial published in 2007, they have showed that there is still around 50% survival benefit, 13 to 26%. But do you, if you really criticize this Japanese trial, you can see that those arms, those who are in the observation arm, those who had not received PCI, 64% patients developed brain mets, and those who are treated very aggressively later with radiation therapy. So are these giving radiation therapy later in this part are not going to influence in the overall survival? What is your opinion?
Well, again, you know, whole brain radiotherapy is such a, I think it's a very toxic treatment, particularly in this cohort of patients who come off the back of chemotherapy. And I certainly in my career have found that giving them whole brain radiotherapy can significantly impact on them sort of 4 to 6 weeks down the line, where they get profound fatigue and tiredness. So I think it has a huge knock-on effect on their sort of performance status. And in these groups of patients, their biggest risk, I would say, tends to be systemic disease relapse. And if you've given them whole brain radiotherapy and they've become impacted in terms of their performance status from that, it can be a limiting factor in offering them further systemic disease in the second line setting if and when they develop systemic disease relapse. The other thing I'd say is, if you look at the more recent chemoimmunotherapy trials, we know that immunotherapy does cross the blood-brain barrier. We know that despite that, the effects of immunotherapy on small cells seems to work in a smaller subset of patients. And interestingly, in the studies that permitted PCI, so both IMPOWER and Caspian, only a small percentage of patients actually received PCI post-induction chemoimmunotherapy or chemotherapy. So I still think that if you can monitor closely with MR, then the potential is you've got the ability to treat when you need to. The other thing is the dose that you deliver. So PCI 20 and 5, there's also controversy in the role of SRS in small cell lung cancer. And there are papers from Japan using SRS to treat patients with relapsed intracranial disease. And who knows, maybe monitoring for disease and then intervening with SRS might give you a better outcome than using whole brain radiotherapy for, you know, disease that would fit within an SRS treatment criteria. So that's what I would say.
I have a question to you, John. You said that the residual portion of the thoracic area need to be radiated, and Shuman told correctly that your subset of residual group was benefited by survival by thoracic radiation. The question is, we know there is always the option of 4 cycle or 6 cycle in cisplatin etoposide in extensive stage small cell lung cancer. So say, let us create a scenario, we given 4 cycle, there is some residual. So shall we give 2 more cycle, or we treat this patient with radiotherapy? What will be the scenario? Or we finish 6 cycle, then we see the residual.
So I would normally give 4 and irradiate. I wouldn't go to 6 and irradiate. I tend to stick to 4 cycles. I don't think there's evidence really that convinces me that 6 is better than 4, even if there's residual disease, you know.
Yeah, so this is the message, Shuman, that you should disseminate. In our common practice, 6 cycle cisplatin etoposide, A to Z is the treatment of extensive stage small cell lung cancer. Then we think of something else. So standard recommendation is nothing more than 4. In exceptional situation, it should be 6, but we should stop at 4 cycle. And if there is some residual, we treat it with radiation. I think this should be coming to your wrap-up portion. My another question to Jahangir is, when we are giving chemotherapy, how we are going to assess the response? I mean, how frequently we should assess by imaging, after how many cycles?
What should be the follow-up protocol?
Follow-up protocol.
Jahangir, right?
2 cycle or 3 cycle?
After 2 cycles, what should be the
After 2 cycles.
modalities?
Sorry?
What should be the imaging modalities?
Best is CT scan of chest.
Okay. So okay, let's discuss the another question in the chat box from Dr. Suryana Sultana. Her question was role of consolidative radiotherapy. I hope we have already discussed this question. Next question from Dr. Altaf Hussain Riyad. Is there any different treatment protocol if patients have paraneoplastic syndrome?
I think no. In paraneoplastic syndrome, treatment divided into 2. One is symptomatic treatment and another is primary tumor treatment. And there is no different protocol. Symptomatic treatment is here very important, and close monitoring and caring also.
I want to give additional very interesting information to Dr. Altaf Hussain Riyad. There is a publication, and they found that those patients who are presented with paraneoplastic syndrome, they ultimately reported with better outcome. So paraneoplastic syndrome is not better, and there will be you can get around 15% overall better overall response those patients with having paraneoplastic syndrome. So the next question is palliative radiation was guys, Dr. Mubassar Hassan from Dr. Mubassar Hassan. Radiation after 4 cycles, 6 cycles. I hope this is already discussed. After 4 cycles, if there is a residual, there should be the radiotherapy, right?
Yes.
What is the role of PET CT scan in extensive stage small cell lung cancer management? Can it impact the treatment outcome? What is the role of PET CT scan?
I think Kamal sir will answer this.
Let me get this answer from Dr. John. Dr. John, what is the role of PET CT scan in extensive stage small cell lung cancer?
So some of my patients will have had a PET scan up front because it will have transferred them from limited to extensive. In terms of imaging on treatment, though, I don't normally repeat PET imaging during therapy. And in fact, often they've got bulky chest disease. So a chest x-ray just post cycle 1 can be helpful just to look at change. And then normally I'll just do CT imaging after typically cycle 3. And so, yeah, I don't do PET. I don't do PET.
So, Suman, I brought this issue intentionally because in non-small cell lung cancer, CT is a fair tool to do the staging, and it is more important for our radiotherapy planning. But in a small cell lung cancer, you see the data that if you do a PET CT from limited stage, around 15 to 20 plus percentage become upstage to extensive stage, and only 3 to 5% downstage to limited stage. So that's why when you do a PET CT in early diagnosis, as John said, not in the follow-up, it really makes a difference of staging, limited stage to extensive stage. So you can tailor your treatment, and this is how it impacts the treatment outcome. So comparing between non-small cell and small cell, here it has a bigger role than non-small cell.
So there is no question in the chat box. I would like to ask a question to Dr. John. So in first line treatment, if all the immunotherapies are available, what should be your combination? Are you in favor of Pembro or Durva or atezolizumab? What should be your first line of?
So in our center, Pembro isn't available at the moment. So it didn't show an OS benefit. So the NHS, as things stand, has only allowed us to access Atezo and durvalumab. And to be honest, because Empower got there first, as one imagines, atezolizumab got onto our hospital pharmacy and has embedded itself, if you like, as our sort of standard first-line treatment. And I think that's always the challenge. You know, the first drug to get there, you tend to cut your teeth on it, gain experience with it, and as a consequence, you become comfortable using it. And in fact, with durvalumab, as I treat lung and breast as my specialties, durvalumab we only normally use adjuvantly in non-small cell lung cancer stage 3. So I don't have a huge amount of experience with durvalumab, certainly compared with atezolizumab, which became our standard second-line therapy in non-small cell lung cancer following the OAK trial data. So we had loads of experience with Atezo, so it was very easy for us to adopt it. And in fact, we took part in the Empower 133 trial in Barts and managed to recruit some patients. So it just became easy to adopt it as our standard of care first line.
But the more important thing is that in case of small cell lung cancer, you don't need to do the PD-L1 and TMB score, right?
That's right. So it's just an all-comer approach. So it's just easy. Yeah.
But though the overall survival advantage is better in durvalumab rather than the atezolizumab, the Caspian is overall survival is better, a few months better than the Empower 133.
I honestly thought it was, essentially I thought it wasn't months. I thought it was a fraction of a month, a week or 2 weeks in terms of OS. Unless there's new updated data I haven't seen, but I thought they were very similar,
Okay. So thank you. Let me summarize today's discussion. If in case of extensive stage small cell lung cancer, our standard of treatment, cisplatin etoposide, preferably 4 cycles. If patient can tolerate, you can go up to 6 cycles. After completion of the chemotherapy, you need to check whether there is any residual in the lung. If there is any residual, you should consider radiotherapy 30 gray and 10 fraction. And you can consider PCI, though John is quite a bit conservative regarding the PCI. He is more prefer MRI imaging. If brain metastasis is there, and they will prefer for radiotherapy. But in Bangladesh context, when there is hardly we can do frequent MRI, so you can consider PCI because URTC trial consider this PCI, and they have found a good overall survival. And regarding the immunotherapy, if the patient can afford, you can consider atezolizumab or durvalumab from the very first line. But you don't need to check the PD-L1 and TMB. You can go straight forward with this immunotherapy. That's all from today's discussion. Now I would like to request Mr. Shomit to again post this poll to reassess our reassess the poll again. Shamir, can you please repost the poll?
Everybody is requested to participate again.
So cisplatin and irinotecan by a Chinese trial, they have proved, but ultimately in the world perspective, they failed to prove. So still, cisplatin etoposide is considered as the gold standard of treatment.
Come on, let them finish. You are giving.
Okay.
Is the poll going on?
Okay.
So, John, in the meantime, I want to hear from you about the toxicity of atezolizumab. It is not a very friendly drug.
I have to say, I find it to be okay, to be honest. I've got, I very rarely see renal toxicity. If anything, it tends to be liver dysfunction. In terms of atezo and Nevo, I have got some patients on Nevo who've been on it for, I think we talked about this before. I've got some who are on it now 5-6 years, you know. I've got one lady who's, I think next month will be on her 100th cycle of nivolumab without any significant toxicity, ongoing complete response from metastatic disease. So I think probably you're right. I think overall pembrolizumab, I probably get less side effects from pembro than atezo, but we don't have access to it in small cell. What do you find? Do you find pembro is?
I don't have much experience with this. So, but what we read, so you know, seeing I have experience with durvalumab.
Next question.
So there was a question in chat box. John, can you respond that? What about the pleural effusion in extensive?
Yes, thanks, Dr. Kamal Bhai. I raised the question. Just to know from the colleagues abroad and in Bangladesh, my colleagues, like in case of complication with pleural effusion, how do you battle with it?
So, John, what is your recommendation? There is extensive pleural effusion.
I would, if they're very symptomatic, I'd get it drained and then start them on chemo.
Use IPC or what? Like, how do you drain it?
So so chances are once they start their systemic drug therapy, it should hopefully be kept at bay. So I would just do a standard pleural drain to allow the fluid out, then start them on drugs, and hopefully it'll avoid it reaccumulating. But if that fails, then yeah, an IPC would to allow fluid out. Sometimes as well, no doubt you'll see patients with pericardial effusions. That's more challenging. So again, we'd normally get them in to have that drained so that they're symptomatically stabilized and physiologically stabilized, and then start them on chemo on the basis that the chemo will keep it at bay.
Okay, thank you.
So the message is actually like non-small cell lung cancer and small cell lung cancer. If it is asymptomatic, we can wait to see the response of the chemotherapy to take care of it, because it is not a very good solution to put a intrathoracic tube, because it can create a pocket, and this impacted insistent effusion become an issue later on if it is not properly addressed. So in non-small cell lung cancer, yes, we prefer more to put a tube, but a small cell, if it is asymptomatic, we can wait or drain for a time, what John was telling. And if it is recurring and it is not adequately taken care of, we can put a tube. That was the comment from John, but we can really differ. There is no right and wrong in oncology, we know.
Thank you very much, Kamal Bhai.
Shuman, can we go to the next question? Yeah. So, poll finished. Shuman, you are muted.
Next question. Proceed to the next question, right?
The last one. This is the last one. Yep.
Yes.
This is the last one, sir.
We are right on time, Kamal Bhai.
Good. I know. I see that. Now, why I want that slowly we should give less time to this poll.
Yes.
Because people should be responsible, because this is the first time, so everybody is learning. And I know this today, many people miss the poll, first poll. So they missed the opportunity to get the award. So next time people will be on time, not to miss the session, because from first question, it is important to be in the lottery.
Can I ask a question?
Yes, John, why not?
So in the UK, small cell lung cancer probably makes up, it's a disease we see less and less commonly because of our smoking rates reducing. So if I see, I don't know, so if I see 40 new patients a month, probably only a handful of those will have small cell lung cancer, maybe two maybe. What's it like at the moment in your practice? How many would you see? So probably about 5% of our patients, 5–10% at most.
Come on. What is your experience? I'm telling my one.
My experience is quite different because I used to see a very large numbers of small cell lung cancer patients. If I consider in my total in 1 month's data, though it is not very recorded data, around 30 or 40 patients, around 8 to 10 patients from small cell lung cancer, and most of them are
around 20% plus patient we see small cell lung cancer, and there is no pattern. You know, it is a middle-aged, senior. I mean, unfortunately, our smoking is still very high, and we are seeing a huge number of small cell lung cancer patients.
Okay, close the poll. Close the poll. So, Kamal, we have completed the poll.
Okay, so let him do the selection, and in the meantime, you can discuss the question. I mean, the correct answer.
Yes, if you can go from the first question.
Samir, show the first question.
First poll.
First poll, Samir, show the result.
First poll result.
First question, yes.
Yes. So carboplatin etoposide in this question, most of them are right, cisplatin etoposide, but though who have opted for the carboplatin etoposide, he's still not wrong. So that the Cockey's analysis give you the authority to choose carboplatin instead of cisplatin. It is already mentioned by Dr. Jahangir Alam that there is no overall survival advantage by giving this cisplatin, but only those are less than 70 years that cisplatin is going to produce better progression-free survival. So considering these things, in 60 years, good performance status, you can consider cisplatin, but otherwise carboplatin is not a very bad idea. So both of these answers are correct. So next poll. So this time this is the same answer. Okay, that's the second poll. Second. So this is the question. It was a quite bit tricky because I wanted to see the idea regarding 4 or 6 cycles chemotherapy. So here you can see that after 4 cycles completion of chemotherapy, there is the residual there. So after 4 cycles, you could consider radiotherapy to the lung and PCI. But those who are still considering 2 cycles chemotherapy, I think it is not a very bad idea because both of these are rational ideas regarding the performance status and the ability of these patients to take this extensive treatment. So I think RT2 lung lesion after 4 cycles is the standard of care. But if the patient can tolerate, you can offer him 2 cycles more, and then you can consider this thoracic RT if there is residual disease. So next,
that there is no very great data to additional of the 5th and 6th cycle to give any survival benefit. Right. So that's why we have the freedom to use 6th cycle, but we should be very cautious. I mean, why I am repeating these things, that standard of care is not 6th cycle. Standard of care is 4th cycle. So in special situation, if I'm really convinced that you said the fitness is performance study is very good and good response, then otherwise we should stop at 4th cycle.
And regarding our last question, that is on the immunotherapy. So the message was there that you don't need to check the PD-L1 score in case of selecting the immunotherapy for small cell lung cancer. And we have already discussed that IMpower33, they have tried atezolizumab and they have found a good significant overall survival. And the durvalumab, that is the Caspian study, it is produced significant overall survival. Pembrolizumab, good progression-free survival, but no overall survival. So you could choose any of these two, but you don't need to check the PDL1. That's why the answer number one answer is not correct. Here the correct answer is 2. But you can consider the atezolizumab, but you don't need to check the PDL1. That is the information, and that's all from me. Now I would like to request Dr. Kamal Bhai regarding our today's first poll regarding the idea, and then we will proceed to Professor M.A. Haisar to conclude this session.
Thanks, Shumon. I mean, we were a bit frustrated to see that only few number of participants were participating in the quiz, and we were scared maybe one will participate and he will get the award. So we were looking for an option. So we moved to this poll. So this is I think it's a good way to see the, in oncology, I always learned that there is nothing absolutely correct and absolutely wrong, but we must have our rationale and logic in favor of our decision. So the poll can give an idea, and after the lecture, we can shift our idea from pre to post. And this will ensure that we can ensure more participation. And from the participation, randomly we'll select the lucky guy, not the intelligent person. So the chance of getting award goes to anybody. But just for information, the organizer has, our higher authority has categorically restricted our name, me, Shumon, and everybody out of the random selection. So unfortunately, we will never be lucky. So this is another information. And I think our main objective of this is always to interact, not to listen. Because in YouTube, you will find great lectures and you can see the world leaders talking. But here we want to listen from our colleagues and we want to discuss among ourselves. And we want to discuss the real life scenarios, what we really face, the 4 cycle, 6 cycle, radiotherapy, yes or no, PCI. I mean, these are the things. Immunotherapy is very good to know, but probably in lifetime, we will get a chance to treat with immunotherapy. So this is a good education, but I think we always need to discuss about our real life thing, say that 30 gray is giving equal survival with 60 gray in small cell. That is a big message, I think, from today's session that our colleagues can carry home. That small cell, we don't need to kill ourselves to give 60 gray in 30 fraction. This is money, this is time, and this is, the resources for a country like us. So I have a question to John, I forgot to raise. I was just reading that ESCO 2020, there was an interesting paper for limited stage that we discussed last week, that they have tried the BID 60 gray and they have found that equal toxicity and showing slightly better survival than the BID 45. Have you seen the paper, John?
I have. I think maybe, did Corinne Favre-Finn, I think she might have done the discussion or maybe even presented it. Yeah.
So what do you think? Is it like that?
Well, I think ultimately, if you can deliver more radiotherapy safely, but without extending the duration, we've seen in the non-small cell trials that trying to deliver higher doses, if you extend the duration of time, it can turn out worse, So I would say my hypothesis is that you're still delivering a higher dose in a shortened period of time. And the dose that you're delivering in terms of cardiac morbidity is not as high as that 74 gray, The fact is 1.5 twice a day is better. So I think that's my idea why it probably results in better overall survival.
Thanks, John. I wanted to ask the colleagues that you can look into the paper. It's very interesting. And I am a believer like John, because repopulation is an issue in small cell lung cancer and treatment duration is an issue. And in non-small cell lung cancer, dose escalation failed because of the toxicity. But if you can manage with 1.5 gray BID, and this could be a game changer. And who knows, maybe we are looking at a time that the small cell will give a higher survival than on a small cell if we can treat. So we can complete, but if Samir can give the lucky person name. Samir?
I've already given it to Shumon, sir.
Come on.
Yeah, you can, Dr. Samia Wahid, today's lucky winner, Dr. Samia Wahid.
Can we see the lucky winner, Dr. Samia Wahid? Congratulations, Samia. Can we see?
Thank you, sir.
Can you just, if is it possible to open the camera? We want to see Samia Wahid, today's lucky person.
Sir, just give me a few seconds.
Okay, so sir, we are almost at the end, and today is a great day for us. I will say that we have a friend from Lesotho. I was doing a Google to find where is the country, and I found it is near South Africa. And I used to see this gentleman in Facebook many days, and I know this gentleman from my medical school. One day I found that he is in oncology. So I said, why not to invite him? And he took the invitation very warmly. And I'm very happy to see our old friend joining us from overseas country. So thanks, Dr. Mubashir. Nickname is Dr.
All right, why not to say, why not to hear some words from Dr. Mubashir? Sure.
Yeah. Dr. Mustafa Shuman, thank you very much. I just want to inform everybody that I am very much glad to be invited by Dr. Professor Kamal Bhai to this fabulous platform of Oncology Club. You know, actually what happened when I started medical school in Mymensingh Medical College in 1989, the same first year, Professor Kamal Bhai was hugely involved in a club called Medicine Club. He pulled my ear from the hostel and took me to the Medicine Club. Actually the same, but not this time I was away from him, so he did not get hold of my ears now, this time. But he did pull me also to this fabulous club. I'm very lucky that I got you guys, and I've gotten a lot of knowledge today from Dr. Shuman, Dr. Jahangir Alam, John, and other participants, and also obviously Professor Dr. Kamal Bhai. Like the confusion between decision making of either after the diagnosis, either radiation, chemoradiation, or palliative management after chemoradiation. So these always makes a big questions in my mind here. So I think this time I have a chance to raise my issues of my patients in Lesotho with my colleagues here in the platform. I hope I will get help from them. And also Professor, we have got a senior professor here. I'm not introduced, I don't know, but I will note sir in time. So Lesotho is a very small, low privileged country where there was no oncology clinic so far. So I was sent by Ministry of Health Lesotho to India. Actually, I'm just giving a brief intro of myself for a training on medical oncology and Apollo Cancer Research in Delhi. Then I came back. Now I'm already a student in University of Cape Town on palliative medicine. So I think you guys will give me informations and knowledge to go ahead with this poor population of Africa, where I can add to the treatment of oncology in Lesotho. Thank you very much to you all.
Thank you, Masum. So thank you, Samia. Now we know who is this Samia. I know Samia. So many of us know Samia. I was not identifying you by name. So sir, we are almost at the end. I am not going to thank John because we are treating him as an insider, not an outsider. So John, good to see you. And we enjoyed today because I think that, as I mentioned, we want to talk about the real life thing rather than the high tech thing. This is very important. And you really, pinpointed the issues that this PCI issue, the 30 gray issue, and the residual issues. So thanks for that. So sir, Professor Hai sir, you can conclude it sir now.
Okay, thank you, Kamal. Very nice session today. Particularly, I congratulate Dr. Jahangir Alam. First time he has presented paper, and he has very nicely presented. Paper was very nice. Thanks, Jahangir, very much. I'm very happy with him. And welcome, Dr. Mubashir from Lesotho. Very happy that he could join us. We could simply join our efforts. We can join our gynae programs as well. And he can ask his colleagues also to join. We're open to everyone. Where you feel any necessity of our help, we're ready to help you anytime, anywhere. So, and as well, we are now going to close it. Thank you all very much, everybody. Good to see you again. Good evening.
Thank you, sir. And I want to remind that our academic partner is AstraZeneca. Thanks to AstraZeneca for your support, and we are very grateful for you supporting us, and hopefully the support will continue. So we finish it here. See you all next week, same day, same time. And what is our topics next week, Sumon?
Next topics, mesothelioma.
So it is not a very common thing, but very challenging thing. Whenever you come across, this is going to be a big issue, because mesothelioma is not the same like lung cancer. So we will hear about mesothelioma next week, and hopefully we will have Masum there. So see you everybody next week, and please try to make it more attractive. Thanks, John. Goodbye.